Okay, when you do the lumbar anatomy, you start from the identifying the structures from down. So the first structure you find is a sacrum, which will be like a continuous.
Show us the morphology first, and then we can get a sono picture where you are now, anatomically.
Okay, you are at the bottom of the. Your patient is in sitting position just now because we are using the same patient. We are using the same probe, and as the same patient is going to have cervical epidural also. So she's in sitting position.
Okay.
This is the obviously the bottom of her.
Okay.
And so I'm going to start paraspinally, means away from the midline, and I'm going to place the probe like paramedian and sagittal plane.
Okay.
So this is where I place
on the capillate side.
So this is the cranial cephalad, cranial side.
Okay.
And cephalad side. The probe is in the paramedian, parasagittal, and then I've placed it on the bottom, at the lowermost part of lumbar spine, I would say. So you see the sacrum. That's the first anatomical structure you see, and you want to see because then that you know where is L5, where is L4, where is L3. So there's a continuous structure.
So the right side is towards sacrum.
Right side, the pointer is at the sacrum.
Okay.
Yeah, because it will be seen as a continuous line now. I'm moving my probe up slowly.
Yeah.
So the first structure I see where you can see the black complete shadowing there.
Yes.
Where the pointer is now is L5 because that's the first lumbar vertebra, isn't it?
Yes.
From down. I go up, I see L4. That is now coming in the picture. I'm getting in the center of the picture, and that is L4.
Yes.
Which will be complete hypoechoic. And what you're seeing are actually the articular surfaces, if not the laminae of the lumbar spine, because you are paraspinal, you are parasagittal.
Okay.
Yeah, you're not in the midline, you're away from midline.
Yes.
So you will see how we do the translaminar approach or paramedian approach, isn't it?
Yes. Yes.
So that's what you're seeing now. Now I'm going to rotate the probe transversely. You can see on the screen there, I'm moving it transversely. See how the picture changes there. Can you see? It's basically complete shadowing.
Yes.
Yeah, because complete black shadowing, isn't it?
Okay.
Because basically I'm pointing it towards the tip of the lumbar spine. So there's no acoustic medium going through. It's a bone.
Yeah.
So now I'm moving it slowly upwards because now I can see between the spine.
Yes.
So that is intraspinous.
Yes.
And what you're seeing, the blackish line from the yellow pointer downwards, yes, from yellow pointer downwards is the interspinous ligament. And then what you're seeing is the posterior complex.
Yes.
And the pointer now is pointing towards the posterior complex, which consists of ligamentum flavum and dura. Please freeze the picture. So what you're seeing is now ligamentum flavum and dura.
Yes.
And now you can see on the picture something called as a bat swing appearance. I'm just showing it through the pointer. Please follow it. Can you see that like a bat swing?
Yes.
So that is that is something you will see when you're interspinous. And now let us measure the depth of the epidural space. So from the yellow triangle in the middle of the screen towards the green arrow, which is the first hyperechoic line, is the ligamentum flavum and dura complex, this posterior complex. And in her, she's a very thin patient. You are finding it at 3.44 centimeters, which is probably expected in her body habitus.
Okay. So you will find the epidural space somewhere at that depth.
That's correct. Now, 2 points to remember that this is an approximate depth because you are, after all, pressing the probe against the skin.
Tissue compression will come into play.
Exactly. So you may be quite happy to go up to 3 centimeter, but afterwards you have to be a bit cautious, and then with the loss of resistance syringe, you will find it somewhere between 3.4 to 3.5. So just
you mean to say it's a very good guide to judge this depth of the space?
It's an excellent guide to get the depth of the space. Yeah?
Okay. Shall we have the other picture now? Okay.
Sandeep.
Yes?
Swarup. This is Dr. Swarup.
Dr. Swarup is asking some questions.
Sandeep, can I ask a question?
Yes, please.
Yeah. Do you think ultrasound actually underestimate or overestimate the skin depth?
It does not tell you the exact depth. It depends on how tissue compression you have got. So it will tell you approximately at 3.44 in her, you will see you should be getting the ligamentum flavum. Once again, I've got the picture here. It's in the center of the spine. Also, everything depends on the position of the patient, because if the patient moves or your ultrasound probe moves, then obviously the depth will be different, isn't it?
Like, what's your clinical experience? What do you think? It's correlated with the ultrasound depth, or it's vary with the how?
It correlates very well to the ultrasound guided estimated depth.
Yeah.
Probably couple of millimeters here and there.
Yeah.
Means from, say, we found it at 3.44, I probably will find it between 3.4 to 3.5.
Yeah. And what's your experience about the thoracic region? Does it actually helps in the finding out-
Thoracic, lower thoracic certainly yes. Upper thoracic probably not as effective, because the ultrasound image is not that great.
Oh, okay.
Yeah.
Thank you.
I have a question. Here you are judging the depth as a perpendicular to the skin.
Yes.
But when you are doing an epidural puncture, you are often oblique. So that also you must be taking into account, isn't it?
Well, you are obviously estimating the depth in the beam of the ultrasound, which is in this case was in the midline.
Yes.
And when you go paramedian, then you can see the ligamentum flavum, you can even measure the depth of ligamentum flavum, but then you will be out of the plane. So you may not be able to get exactly the same depth, because you are
Yeah.
completely out of plane. If you go in the plane, then you should be getting the epidural space exactly at the same depth you found it.
Yeah, that's
in the
right. So
image.
obliquity, the compression and the plane, which is paramedian, all are going to change the depth to some extent.
No,
So we got that.
My point is that if you have got a clear depth with the midline view, for example, here, then I will obviously go in the midline. I will not go paramedian. If I'm going paramedian, then can you just freeze this picture, please? And then please, if you could take the pointer at ligamentum flavum, which is that, yeah, that's the ligamentum flavum.
Okay.
So you still can measure the depth,
Okay.
but when you are going paramedian, you really are going completely out of plane, because you are going to take the probe out, and then you don't know which level which direction you are going.
Okay.
Thank you, Sandeep, for that
Okay, right,
excellent
yes.
demonstration on the sonoanatomy of the epidural space.